Welcome everybody to my one-year progress report. My PhD topic is about anterior cruciate ligament injuries and osteoarthritis in the knee joint. I'm Jonge from Uzsoki Street Hospital. The vision of our team is to understand the nature of sports injuries, provide better care and life quality for knee injured patients. And we think that we could achieve this by resolving disagreements and controversies of anterior cruciate ligament injury and therapy. We have two ongoing projects right now. The first one is non-operative treatment of ACL tears versus reconstruction, and the second one is adding an extra procedure to the reconstruction. So the first topic. ACL injury leads to instability, which is a major risk factor of early onset osteoarthritis. In the US, there are more than 1,300,000 ruptures reconstructed a year, and in Hungary, it was about 3,500 before the COVID pandemic. The gold standard treatment is surgical reconstruction, primarily due to its associated improvements in knee stability and better restoration of activity, and conservative treatment is reserved as an alternative. However, with a good rehabilitative treatment, stability can be effectively regained, as well as it eliminates the risk of surgical complications. So despite ACL injuries are well studied, until today we still do not understand which option is potentially better to prevent osteoarthritis, and basically this is our aim to find it out. We were investigating isolated ACL ruptured patients with reconstruction, compared them to conservatively treated ones, and focusing on radiological and functional scores. We had more than 13,000 articles, of which just a few, 5 articles could make to our final evaluation. But let's talk about results. Radiological signs of osteoarthritis. There are clear signs of joint degeneration on the X-ray, and there are different grading systems, but there is a clear cutoff value between normal and abnormal knees. So we had an easy way to evaluate this outcome. The pooled odds ratio is 1.84, which means there is almost 2 times higher odds to have a normal knee for the conservatively treated patients. Despite this is a really strong effect, sadly there is no significant difference. Arthrometry measures the anterior translation of the tibia and comparing the injured and normal extremity. Here the pooled mean difference is minus 2.44. It means there is about 2.5 millimeter less instability in the reconstructed knees, and this is a significant difference. However, we are not really surprised, because the goal of reconstruction is to have a more stable knee. Ligament score is a patient-reported subjective outcome on a scale from 0 to 100. And here there was a mean difference of 2.88 and no significant difference. However, this is on a scale from 0 to 100, not even 3-point difference is not clinically meaningful either. So as a summary, radiologic science favors conservative treatment. Arthrometry has significantly better stability for the reconstructed groups, and the Ligament score favors, we have interpreted that it favors conservative since it's neither mathematically nor clinically meaningful. Also, we have created a review table of the outcomes, because we had a lot of outcomes, only 3 were mathematically analyzed. And you can see here just a few favors reconstruction. There is one, the arthrometry, that is significantly better for the reconstruction, and all the other one favors conservative, or there is no significant difference. Also, we created a table of the subsequent injuries and surgical interventions needed in the follow-up period. And the fourth and fifth study, which were RCTs and good designs, there was no need for further surgical interventions, and there were no other injuries. In the observational core studies, there were a trend showing that maybe reconstruction has a protective factor. So the strength of our paper is that this is the most comprehensive literature review available until now, and we strongly hope that our findings and suggestions could serve as a recommendation for study designs and may affect the guidelines in the futures. Of course, there are limitations. We had just a few studies with really wide variety of outcomes. There were poor data reporting. We only had 2 RCTs, but maybe the most important one is that ACL reconstruction techniques were heterogeneous through the studies. We conclude that our results support that conservative treatment could also be an option for this specific subgroup of ACL injured people. In the practice, this means that we should consider conservative treatment primarily. And for the research, more RCTs are needed with standardized research protocols and outcomes, as well as studies with more specific subgroups. So we have completed the manuscript and it has been sent to language editing. We are planning to publish it at the British Journal of Sports Medicine. So a few words about the second topic. As I said, ACL injuries is one of the most common knee injuries, and the gold standard treatment is reconstruction, which has good to excellent results. However, up to 25% of patients experience residual rotational instability of the knee, which is associated with poorer outcomes. And anterolateral extra-articular procedures are aiming to reduce this rotatory laxity. And our aim is to find out if this is a superior technique than reconstruction alone. This is the clinical question as well. We are planning to investigate patients attending ACL reconstruction with the extra-articular procedures and comparing them to reconstruction alone, focusing on knee stability, functional outcomes, and most importantly, the graft failure. And we suspect that this could be improved by the extra-articular procedures. For the clinicians, the most important outcome is graft survival, because if we do a big surgery that costs a lot, then we don't want to redo it again in a short period of time. We have done the systematic search, received almost 6,500 articles, and we are doing the title and abstract selection right now. So this is where I am after 1 year in the translational medicine program. Thank you for your attention, and as always, my motto is only time I set the bar low is for limbo. Thank you very much.
Thank you very much, Robbie, for your presentation. I ask you, based on your findings, what is your treatment option? For instance, a 40-year-old patient with an isolated ACL rupture because your findings a little bit different that we did so far in the clinical practice. Therefore, I ask you what would.
Yes, thank you for your questions. It's a really important question, and you're absolutely correct that our findings are exactly against the clinical practice in the last decades. So basically, this depends on the needs of the patients, the initial instability after the injury of the knee. So first of all, I would suggest the conservative treatment, because later on we can always operate. But if we do the operation, then we can switch back to the conservative treatment. So, for example, I would suggest in this situation, try the conservative treatment at least for 6 months, do the physiotherapy, and if there is a satisfactory dynamic stability for this patient, it fulfills his needs, then we can stay with the conservative. But if there is not enough stability, then we can switch to the surgery anytime. Also, if there is a subsequent injury, other injuries in the knees, we can switch again.
How do you mean instability? I mean based on subjective or objective factors? So
both of them.
Both.
Congratulations, Robbie. It's a fantastic progress in 1 year. I was just wondering, because I can't remember actually, that do you have changes for these outcomes, or these are only after values?
These are only after values.
I see,
yes.
Because otherwise I wanted to state that you should say that both interventions had the same efficacy. Meaning that actually both of them are effective, but there is no difference between them.
That's correct.
So, but you have to pay to care or to pay attention to this, because you are not collecting all conservative data and all reconstruction data from the literature. So that won't be necessarily your conclusion. You were only looking at the comparison of it.
Yeah, yes.